Hello, everybody.
Famous here.
Welcome back to the Incubator Podcast. We are live at the CHNC in Denver, Colorado, and we are joined this afternoon by none other than Incubator veteran, Dr. LeeAnn Pavlek. LeeAnn, welcome back.
Thank you, everyone. Great to be
So, for
here.
the people who don't know, you were one of our guests last year. You have your own incubator episode that recently was released with other members of the Tiny Baby Collaborative. So it's great to have you back. You're based out of Columbus, Ohio, and Nationwide Children's Hospital. Also joining you today is Ulana Pogribna. Hi, Ulana.
Nice to see you.
Nice to see you. Good afternoon. And you are coming to us from Oklahoma, if that's correct, right?
That's right.
Oklahoma Children's Hospital. And I think it's always very interesting to talk to you guys about small baby initiatives related to the CHNC, because we know that this is one of, I don't know, maybe I'm going to go on a limb here, but one of the most active focus groups. I think there's always something either going on or in the works.
Sure.
So I'm going to try to stay silent and listen, because I'm curious to hear what you're working on next.
Yeah, I think it also helps for us, too, that we're not focused on one disease in particular, but this whole gestational age range. So we have a lot of things to choose from for our focus group in terms of what we're looking at.
And you actually gave one of the keynote speeches today on the first day of the conference, the development and needs of a small baby unit. So tell us, what are the take-home points?
Yeah, it was great to be invited to give that talk, honestly. So I think I try to give some points about the evidence for why it's important to have one of these units in terms of benefits for patients. Certainly it makes sense, but some evidence in terms of improved mortality and other improved outcomes. And then a lot about where our program kind of got started from. We formed our program 20 years ago, before I was at Nationwide Children's, and really have grown and evolved throughout the years. I think the key take-home points are really to have a team, a multidisciplinary team who is really invested in these patients and thinks that they can do well. So an optimistic group.
So lots of units are taking care of little babies, but it sounds like there's a theory that having a team dedicated caring for these babies, theory supported by data, that outcomes are better when people who are used to taking care of little babies are the ones taking care of little babies.
Yep, absolutely. We know that they're very different in terms of physiologies, risk for morbidities and mortality. So having that group who enjoys caring for these patients and knows how to care for them is really important.
You said something very important, I think, that there are some people who love their job in the NICU, but don't love caring for little babies. And, I think that's true for so many different pathologies that we see in the unit.
And we're allowed to say that.
So I think it's good to be honest about, because then people can self-select into being a team that cares for little babies, being on a team that cares for the chronic lung disease, things like that. I think that's there's
I really
value.
like small babies, so
Okay.
I just want to make sure for the audience that I'm not the person she's talking.
You like caring for all the things.
No,
I have my areas of interest, but that's the point of today. Anyways, what is the minimum necessary? Who do you need on the team?
So ideally everyone, but I think certainly
Noted.
at least the most important bedside care teams who are nurses and respiratory therapists, and then our physicians and nurse practitioners and PAs. And then certainly it's very nice to have buy-in from other groups. Our PT and OT colleagues have fantastic guidelines for how to care for these patients in a way that supports their development.
yeah.
And then certainly the folks that help support our families, so our psychologists, social workers, we have NICU parent advisors, I think are all bonuses as well that help care for the patient and their family as a whole.
And what are the other components then of a small baby team? So you've got the team, you've got the personnel. What else?
Yeah, we talk a lot about certainly the medical guidelines. That part makes sense, right? But then what are we doing day to day at the bedside to help support these patients, both with their medical needs as well as their development? And how do those things change as these patients are getting older? We talk about just the layout of the NICU in terms of single patient rooms versus open bay pods or other shared patient spaces, and how both have their benefits as well as their downsides for patients.
For sure.
And then a lot about the program as a whole, how we get the team to be engaged, what we're doing for ongoing education, support for the entire team. Those are all important.
And I think a lot of units who are just starting might say, then what's the right meeting frequency? How often do we need to be getting together?
Yeah. So I was here, we wrote guidelines for 22 and 23 weekers that I was really involved with. And those we met a lot at first, both the entire group as well as broken up into different subgroups who wrote the pulmonary part or the fluids and nutrition part. So that was almost a every week, every few weeks to get things written and implemented. And then we have, depending on the group, usually monthly meetings, whether it's our attendings to talk about difficult cases or changes to the guidelines, as well as every few month meetings among our staff. So everyone can be together in a room or virtually and talk about how are things going, how are the patients doing, and what's our next step.
And so, as a segue to that point, Ulana, you had a workshop talking about developing ELBW standardized guidelines. And I feel like a lot of the frustration with that process specifically is that the care can be sometimes viewed as so complex that there's always quick fragmentation of the guidelines. Say, well, let's focus on then the delivery room, or let's focus on the pulmonary management. And then suddenly you find yourself in these subsections of what you were hoping was going to be a single guideline, and then making sub guidelines, and it becomes this overwhelming task. And so I'm hoping that you can share with us what is your advice? What are your tricks in order to stay on target, stay on mission, in order to actually achieve this goal of developing a guideline for your institution, your group of institutions?
Yeah, thank you for asking that. Overall, I don't think you can have a completely singular guideline for such a big group of babies. And so our approach overall was to actually break it down and have key stakeholders in each section, but have a group of champions that carried all of this forward and steered the ship, so to speak. And that was going to be part of the workshop about how we did it and some of the advice and key points that we see. Because, for example, you really can't necessarily just completely say, I only care about lungs, but I don't care about cardiovascular system. Oh, by the way, for nutrition. But we utilized key experts in our institution who were champions for each of their individual parts, and then we came together. And I think those were the strongest, key points of our guidelines. So we could consider them comprehensive guidelines, but it's not a singular one.
And what do you think it's important for people to know, that it's, especially as these guidelines are being developed, that it's okay if you're not covering everything right off the bat in your first draft? Because as you said, you may say, oh, let's focus on the lungs. And then you say, well, then if we're focusing on the lung, we should do the cardiovascular. And then somebody might say, what about the kidneys? But maybe it's okay to say, well, right now, let's focus on this, and then continue to evolve and make this more of a living process, rather than trying to cover everything at once, especially if the champions are not always present. Let's say you do have a group of champions and it includes a few areas of interest. Maybe that's what you should focus on, and then just try to get something done with that group.
And no, I think absolutely. And I think that just the key point of continuous improvement, that this has to be a living organism, and that it continues developing and refining.
Right.
There's never truly like a completely end product. Also keeping in mind that new data comes in, new practices come in, and your guideline for anything cannot be so static that you cannot change it with demands of the unit, demands of the babies. Should be tailored to the unit and organization and actually what capacity each place has.
And then I have the same question for you. If a unit is just starting out, what's a recommendation for like the lowest hanging fruit? Like, where should we start if they're like, we want to organize, we want to start making our guidelines. Where's a low bar to entry, I guess?
I think the lowest bar to entry is really look at your biggest pain points. And that can come
So you're
from
saying that might be different for every unit?
It might be different for every unit. Some of it may be from your benchmarking data, either from CHNC, or when we started, it was from our one Oxford network, and really looking at the outcomes of where are we excellent and where do we need to improve. And I think every unit has those. So I would say the lowest hanging fruit usually is your biggest pain points, and it's easiest to get your champions across.
Because it frustrates so many people.
And you can find a
People can
common
feel it,
language
yeah.
really fast.
I like that a lot.
LeeAnn, in your keynote, you had one slide that talked about the small baby program vision. And I think there's a few things that you highlighted in there. And two of them, I wanted to ask both of your opinion, which are that small baby program have to be patient-centered and interdisciplinary. And so I think that when we're talking about champions, then that means also bringing in to this program the families, and maybe families have to take a pretty central role, but also are subspecialists and our consultants in how we manage these babies. Could you both talk about how you're making this vision a reality in your respective units?
Yeah, we are very lucky to have NICU parent advisors who are the parents of former NICU patients. A few in particular had small babies as their NICU patients. So they are very involved with all of our things that we're doing, whether it's medical guidelines, research, QI, to provide that parent perspective and say, this sounds great, or maybe we should focus on, you should tweak this language or change this kind of thing.
Yeah.
So we have them as a great source of input.
This one.
So I think that in addition to bringing all the medical specialists, it's really important to bring other specialists like child life specialists or, your occupational therapy, speech therapy, etc. Because those and your nursing teams, because all of those members bring a somewhat different perspective and can really make the experience richer and frankly better for the baby overall.
Yeah, we don't utilize child life enough in the NICU.
Yeah.
The PICU gets all the glory with child life. We don't get enough of it.
I wanted to highlight some things that you guys are already doing, the extremely preterm infant focus groups. You have 3 subgroups I see. You told us a little bit. Development of the small baby unit and team, specifically focusing, then the second, specifically focusing on the care of the 22 to 23 week infant. And then this idea about tools for shared decision-making, prenatal counseling, and ethical issues. I'm curious about some of those tools and also the CHNC PREME report.
Yeah, so that third project, we're actually doing an abstract for PAS. So we're currently looking at those numbers and our survey results. And that's really broken into 3 different categories, looking at what are we doing just in general for the care of these peri-viable babies? And interestingly, what do different units define as peri-viable, which is not the same thing across centers.
I'm sure.
And then looking at what tools exist, how are we counseling families? Do we use different numbers from the NICHD or local data? And then how are we training our fellows and other staff in how to do these consults? So that's been very interesting.
So
How different we are.
We're looking forward to hearing that at PS. What does
Yes.
the future of the PREME infant focus group look like?
That's a good question. I think that we have had a lot of new folks join recently, some new hospitals and just a lot of new members. So hopefully after this conference and everything has calmed down a bit, reassessing what's next, what else can we do to take advantage of having, I think 49, they said, centers in the CHNC.
That's excellent. Excellent. Okay.
Ulana, LeeAnn, thank you so much for dropping by and for sharing your thoughts. Congratulations on this great work and have a good rest of the conference.
Thank you for having us.
Thank you for having us.
Thank
Our
you.
pleasure.